right, now that I've got that organized, I'm gonna introduce Sissel. Are you good to go, Sissel?
Let's do it.
All right. We've got a special guest, it seems. That's awesome.
I do. I'm just mixing a couple of worlds here today. So
Yeah,
we've got a little guest. Her name is Lily. She's 7 months old, and unfortunately has had a bit of an infection here in these last couple of days, and so she's just not feeling her greatest. But she will be chiming in today.
gotcha. Okay, well, we'll just do a quick intro, oops, of you and your work. So Sissel has recently completed her MSW research with emphasis on intellectual disability and aging. So we're excited to hear a little bit more about that research and the passion that Sissel brings to that work and the combination of intellectual disability and another neurocognitive disorder of dementia and aging. She's currently the director of resident supports with Elmwood Residences here in Saskatoon. And we would also just like to add that I am coming to you and Sissel is coming to you on Treaty 6 territory. So we want to provide that land acknowledgement. And we know that our colleagues from all over the province are joining us from various treaty territories as well. So thank you so much for your time, Sissel. We're really excited to hear you share with us today. So I'll let you get started.
Awesome. Thank you so much, Holly. And funny enough, Holly and I used to work together a few years back, and so when she reached out to me a while ago asking if I would be willing to do this, I was so happy to. Like, this is definitely a subject that is near and dear to my heart, and you guys will learn a little bit about my journey and how I've kind of gotten into this field, and particularly when it comes to kind of intellectual disability and aging. But yeah, Holly and I, we go way back. So thank you so much, Holly, for inviting me for this. I'm really excited for it. So I'm going to go ahead and share some screens here. I'm hoping anyways. Let's see. It's popping up for me.
Did I make you co-host? I think I did.
I think so. There it is. Oh, yeah.
Yeah, let's. Does anybody have a speaker they want to hook her up? I don't know who would just.
Go ahead. So I think
Check it for you guys. Just give me a second. So you guys don't have to see all my notes. There, okay. Now you guys should see only the presentation, right, Holly?
yeah, we're good to go.
Perfect. So, intellectual disability and neurocognitive disorders. I will get into some definitions because some might not be familiar with the term neurocognitive disorders, but essentially what it is kind of the newer term for what we would call dementia. Okay, so we'll get into that in a little bit. I just wanted to first off say thank you everybody for coming and for taking your time out of your busy days. I know it's lunchtime, and so I'm hoping I can be here to inspire and motivate today and maybe spark some extra interest in this in some folks. And also, as I'm sitting here with my baby, if you felt that this week was going to be a bit tough, I'm here to tell you you can do it all. Okay, so off we go. I also wanted to start off with a land acknowledgement. Thank you, Holly, for doing that. And so we do acknowledge that we're on Treaty 6 territory and the homeland of the Métis. And we want to pay our respect to the First Nations and Métis ancestors and reaffirm our relationship with one another. Okay, so this one is just really quick about who I am and why can I sit here and talk about this subject? Okay, so my name is Sissel Prediger. I actually completed my bachelor's degree in social work back in Norway. That's where I'm originally from. And I moved to Canada in 2012 and started in the intellectual disabilities field right away. And so at this point, I have 10 plus years of experience working in the field, both nonprofit and government sector. So I've worked my way kind of starting at group homes, working kind of that one-on-one support into the government, where I was a part of the clinical team there, working crisis and program development. And I'm sure I have some, I know I have some old coworkers on here today, so it's nice to see. And then a few years ago, I decided to pursue a bit more of kind of a leadership route. And so I went back into nonprofit, then with Elmwood Residents, where I'm currently holding the Director of Resident Supports position, though I am on maternity leave right now, but I will be back. So I've also completed research practicum on the topic of intellectual disability and neurocognitive disorders. So I started that journey in like 2017, 18, and then I have had 3 kids at the same time. So it's taken me a little bit longer, but we're done now, and I'm ready to kind of share this knowledge with the world. So I'm very excited for that. I'm also a certified trainer in person-centered thinking through Helen Sanderson and Associates, and that's important to note for later because I'm going to talk a little bit about some tools that we can use. And then I've also completed extensive training related to supporting this population as they age through the National Task Group on Intellectual Disabilities and Dementia Practices. So that's where I'm coming from with all of this, okay? And I went back and forth on how I wanted to do this because I could easily make a 2-day workshop on this project or on this topic, but Holly didn't give me that. She only gave me an hour and preferably also time for questions. And so she kept me in line for that. So I think what I want you guys to kind of take away today is hopefully some additional knowledge and tools to use when you are supporting this population through the challenges of aging. And also, I'm not focusing overly on the actual diagnosis, where in the brain it sits, all of those types of things, because I just felt that maybe that wouldn't be useful for my audience for today. But if you're more interested in discussing those things, we can do that at a later time. So we are going to go through some key terms and some stats and facts and some definitions before we kind of head into the research findings from my completion of the MSW. So for key terms, some that's on here today will know this really well, and some it might be new to them. So the Community Living Service Delivery, CLSD, and I am notorious for using the acronym CLSD. So this is a branch of the Saskatchewan Ministry of Social Services that assists individuals with accessing other community-based services across the province. So when I say that I work for Elmwood Residences, which is a nonprofit, we are funded by CLSD. So because of CLSD, we get to operate, okay? Early detection screen for dementia. This is the EDSD. This is a screening tool that's used for early detection of dementia in individuals with intellectual disabilities. I'll show you guys that today and where to find it, okay? Then there's the National Task Group on Intellectual Disabilities and Dementia Practices, the NTG. This is technically an American nonprofit organization, though there are folks in Canada too that would have all the resources and that does the same kind of training here in Canada. But they provide resources and information for supporters and caregivers. So you can essentially go onto their website and there's a whole bunch of resources. And I've given Holly a couple of links, and I will let Holly know when to post them in the chat so you guys know what they are. And then there's the Comprehensive Personal Planning and Support Policy, which is CBP-NSP, which is the policies that we follow when we support individuals with intellectual disabilities, government, nonprofit, and it's developed to support individuals with a focus on decision-making, autonomy, and respect. So if you guys hear those acronyms, this is what I'm trying to refer to. So some quick stats and facts. So we're actually sitting at about 1.1% of the Canadian population that are currently living with an intellectual disability. And after the age of 60, 6% of these individuals will develop some form of neurocognitive disorder. And this number is what it is. But even when you're thinking about expectancy for this in the 1930s, the mean age for them were about 19 years, and at 1990, it increased to 66. And I was actually having quite a bit of issues finding updated stats on that when I was doing my research. This is the most recent one, but I mean, just from professional experience, I will say that I have supported folks all the way into 80s. And so at the end of the day, we are going to be seeing these individuals displaying other signs of aging like everybody else.
Okay, yeah, sounds good.
Sorry, can we just have the one person who is speaking to mute so we can hear Sissel?
I muted her.
Okay, awesome. I can't get into it through my angle. Thanks, Sissel.
I got it. And so services offered in Saskatchewan right now are group homes, group living homes, supported independent living homes, and day programs. And these programs are all funded by CLSD, and the support is guided in the policies of CPP and SP, like I just talked about. One thing that's important to note is that individuals that live with Down syndrome actually have quite a bit of a higher chance of developing neurocognitive disorder, sitting at a 50 to 70% chance of developing it after the age of 40, which is really early. So some definitions just on intellectual disability. So intellectual disability is characterized by significant limitations in both intellectual functioning and adaptive behavior. So this would be like everyday social and practical skills. And it also talks about things like learning, reasoning, problem solving, and with the adaptive behavior, things like social skills, practical skills, conceptual skills. So anything from, reading nonverbal cues and how to appropriately communicate with another person and what is considered polite and these types of things that can be sometimes challenging. And then in the context of like the social skills, there's also the self-esteem, the problem solving, the ability to follow rules and laws. And things like money management can be tough sometimes. Concept of time, we're kind of, and then sensory challenges. So, I mean, we're already kind of meeting quite a few challenges already without the development of a neurocognitive disorder. So then when I move into the next one here, which is the definition of neurocognitive disorder, you can see that it affects all aspects of functional ability. So anything from memory to language skills, ability to focus and pay attention, reasoning, judgment, sensory perception, and ability to sequence tasks. So at the end of the day, when it can be really tough to diagnose because these individuals already are experiencing most likely some challenges related to kind of that cognitive piece. And then when you then add on a diagnosis of neurocognitive disorder, it can be really, really tough to diagnose. So neurocognitive disorder used to be known as delirium, dementia, and amnestic and other cognitive disorders. But the proper term right now is neurocognitive disorders. Though I'm using some articles in this one that will probably, they will be using the term dementia here and there. And that's purely because it's in the title or I'm quoting it. And so you guys will kind of see me using both of them. So based on my research and also some professional experiences, I would say, we are facing some gaps and this is like Saskatchewan, but I would also say kind of nationwide. There's a bit of a lack of training for staff members to support this dual diagnosis. It can be quite challenging sometimes. And also a lack of resources to support the population as they age. And I kind of just put in here kind of group homes versus long-term care, because the question comes up, right? So someone is aging, maybe they're in their 70s, they're developing neurocognitive disorders, the behaviors are being too much, for maybe the group home to handle, and then now what, right? Do they go to long-term care? But then long-term care might say, well, we might be equipped to deal with a neurocognitive disorder, but what about the complexities with them also having an intellectual disability, right? So that's kind of where you get stuck in the middle sometimes. There can sometimes be challenges related to the CPP and SP policies regarding restricted procedures, the safety of them when they go through the stages of aging. This is a tough one too, and I will be highlighting a couple of articles from Europe, some research that's been done in Europe in the kind of the last 10 years, where they talk a little bit about surveillance technology and kind of how they're using that as a safety measure. And then it can be challenging for organizations to collaborate with a dual diagnosis to make sure that there's a wholesome support and treatment plan. Because so individuals with intellectual disabilities are funded, supported by social services. The diagnosis of a neurocognitive disorder might fall under kind of the umbrella of health. And so at what point can we come together and make sure that there is a wholesome support for this population? So that's what I'm going to be talking about a little bit today as well, related to other countries and what they've done to ensure that collaboration, which is really interesting. So I want to start off here talking about this national strategy. So this was actually developed in 2012. So it's been a while, okay? It's called My Thinker Is Not Working, and the full document is available online, and I'll let Holly kind of put the link in if people want to save it and read it later. And it essentially talks about recommendations for improvement of these services for these individuals as they age. And so they have kind of 4 overarching goals, which is to better understand neurocognitive disorder and how it affects them. It's to institute effective screening and assessment for them. And it's to promote health and function among adults with intellectual disabilities, and also to produce appropriate community and social supports and care. And so because it is a progressive disease, it's just important that the individuals have a safe place to live and that they have proper support from staff or caregivers wherever they live. And that we make sure that their daily routines, you know, stay fairly consistent to make sure that we also kind of maintain those skills that they have so they don't deteriorate very quick. Now, group living environment can be challenging when good quality support is needed. It's not impossible, but it's challenging because there's often roommate pairings. Sometimes there's not enough team members on site and all of those things. But at the end of the day, what I kind of took away from this document was that they've been seeing the challenges for a long time, but it's time to also do something about it, right? So challenges are highlighted. Let's roll with it. Part of my research involved a small case study. It was a small sample, but I did some interviews with some individuals that had fairly extensive experience working in the intellectual disabilities field. And this quote here is from an advocate for individuals with intellectual disabilities related to system development. And I would like to highlight that because it's a really good quote. Which is, if there isn't a clearly defined threshold or trajectory point where you would pause and consider, it's left ambiguous and a team might go too far without that guidance. So think about working or living with an individual with an intellectual disability who is also now experiencing signs of neurocognitive disorders. The changes might be very subtle, okay? And so you might one day be like, oh, I guess today they forgot that they thought it was Thursday, not Wednesday. Like just super, super small things, right? And then you just let it go because you chop it up to, oh, okay, well, maybe they had a bad sleep, or, you know, like maybe they're confused about something else, or maybe we changed the routine a little bit. And so because there isn't that kind of set threshold, sometimes we miss it. Very often we miss it. And then it reaches a point where it's too late. And then now we're experiencing behaviors that we weren't prepared for. And now we're going to have, maybe they have to move because it's not safe for them to live there anymore. So that's why I like this quote, because I feel that I very much agree with it, which is where I want to bring in this early detection screen for dementia. Okay. So Holly will send this link out to, this This screening tool is available for anybody. It's free. You can just download it, print it off. The thing with this one is that it's a screening tool. It's not set to diagnose. That's very important. But early screening is really important so that we know how to potentially modify the support that we provide. And it'll kind of talk about changes in our adaptive skills, in behaviors, and in condition, and it can be brought to the doctor to show changes. Because when it is determined early that there is a diagnosis of neurocognitive disorder, there is time to plan for the future. And that's really important to do, because at the end of the day, we want to make sure that people can age in place and be safe and happy until the end. So families and caregivers and staff members should work together with the individual if possible when we're completing this early screening. So it's not just one person sitting in an office and thinking, I'm seeing some changes here, I'm just going to kind of cross that off. It needs to be a team effort where people come together, because people observe different things. And the recommended use, now here's your threshold right here. So individuals living with Down syndrome, this one should be started at age 40, and it can be done every year unless you're seeing some drastic changes and you want to do it every month. You want to do it every 3 months to track those changes. As for individuals with other intellectual disabilities, about age 50 is the recommendation from the National Task Group. So it's a good tool to use, and also to just educate, the doctor about it. In all reality, there's a little blurb kind of on the front page of the screening tool that talks about what it is and what it's used for. And so it's fairly easy to use. You don't need any additional training really to do it. Just make sure that it's a collaboration and not just kind of a single silo sitting and filling them out. So with my research findings, one of my research questions were related to that residential support. And I found that there's two kind of main residential component or residential options for folks with intellectual disability and neurocognitive disorder. So the one was family caregiving, where families decided to have the family member stay in their home until palliative care and then end of life. And others, it's group living. Now, what's important, and I've said this before, and I'm going to say it many times throughout this presentation, is aging in place, because we want to make sure that people don't get confused. When you move someone, that's huge. After the development of a neurocognitive disorder, that can promote lots of confusion. So if you are working, maybe you're a caseworker, maybe you offer respite, maybe you offer outreach, anything like that, any sort of service to family homes supporting an individual, it's good to note these the support staging model and how you can help in the different stages. So in the diagnostic phase, we want to make sure that whoever the caregiver is seeking help to ensure that there is a proper diagnosis, and also start to kind of look for that understanding about behaviors and changes in functional abilities that will come with a diagnosis of neurocognitive disorder. And then in the explorative phase, we want to make sure that caregivers are informed and educated about the diagnosis and also comorbid conditions, if there is any. And then understand the information and plan for the future. What does the future need? What do you need for alternate care? How are you going to support this individual throughout the end of life? And what are the different scenarios that you might run into? And then in the adaptive phase, that's when you kind of monitor the behaviors and the functions in the individual. And then you might have to adapt certain care practices to better support them. So this is kind of where the respite might come in. Maybe there needs to be some home modifications based on the environment. That's typically completed in this phase. And then in the closure phase, that's when we plan and support the end of life path. Make sure that if there's any advanced healthcare needs needed, we have that in place, and then engage in palliative and hospice care, if that's applicable. Now, if we're supporting within a group home environment, first off, it's important to determine whether or not the organization is committed to supporting individuals kind of through the diagnosis of neurocognitive disorder and then until the end of life. And things to look at is obviously staff training, staff capacity. What does that look like? Looking at things like the environment, which I will talk about environmental modifications in a couple of slides, and also roommate pairings. Like, how is that going to work when someone change? Because cognitively they will change, and how does that work with current roommates? And agencies who do commit to aging in place needs to be prepared for what's to come, which might include, we need extra support. It might include, we need to change some stuff around the house to make sure that it's safe for them to live there, that kind of stuff. And so in all reality, all I would ask is make sure that you commit and make sure that you're willing to carry this on until the end of life, because that's what's best for that person. Now, in order to plan for the future, it's good to have systems work together because that might look different. And so one agency, might have resources in terms of nurses, for example. And I say that because Elmwood Residences, we're fortunate to have nurses on staff, but not everyone does, right? So what does that look like if you don't? And so I pulled out a couple of examples here, one's from the Netherlands and the other one's from the UK. So these are tools that's currently being used in the world to ensure that we're planning for the future. Okay, so one of them is called the Disability Dementia Care Pathways. This is the one from the Netherlands, which is essentially multidisciplinary teams coming together to create specific support plans for the individual for now and for the future. So whatever that looks like for them, related to healthcare services, is there any blood tests needed? What about palliative care? How does that work? And then kind of setting all of that up so that when the time comes, it's not just a scramble, okay? So this is a really good tool. Again, you can Google this if you want and it'll pop up. If not, I have all these articles saved somewhere in the deep folder of my MSW on my laptop. So if you want to see it and you want me to send it to you, I am more than happy. The other one is the dementia care mapping, which essentially it's like a support plan, but again, it talks about now and it talks about the future. So this is from the UK. It's used mostly to support staff members because they also obviously have a hand in the planning, should have a hand in planning and the observations and the tracking that goes into it. So this plan actually uses systematic observation and analysis and feedback from staff when they make it. And then you create action plans after reflection on their work based on what the individual needs. This is just another one where agencies come together, organizations come together to provide that wholesome support for this population. Do you have things to say? Huh? Do you have things to say? Okay. Thanks for bearing with me, you guys. So environmental modifications. I could go on and on about this. There's a whole bunch of things that we can do to make sure an environment is supportive and safe for someone who's going through these cognitive changes, okay? But I'm going to highlight a few here that I would say are like fairly easy to do and very cost effective, okay? So the use of colors and contrasts. So you guys can see here, I have a picture of a dark light switch on a light wall. That's because when someone is going through the different stages of neurocognitive disorder, sometimes their vision gets impacted. And seeing things that are all kind of in the same color spectrum, they can't differentiate what's what. So if this was a white wall with a white light switch, wouldn't be able to find the light switch probably. So it's just a really easy change where you add that contrast in, and then it's more visual for them. The other thing here is that there's a white plate of white spaghetti. often I hear like, oh, well, the progression of neurocognitive disorder is there and they just stopped eating all of a sudden. They just don't want to eat anymore. Okay, well, what are we serving? Well, if you're serving something like this, they're actually not going to be able to see it because it's all the same color for them. Okay, so making sure that you add different colorful things, even having like different compartments on your plate, maybe the compartments have different colors so that there is a bit of a contrast there, that would be helpful. Just to make sure that they know what they're eating. And then using visuals as opposed to written labels. So, I mean, in a kitchen, maybe in a bedroom, we could, there's drawers and cupboards and it might say forks here and shirts here and stuff. Changing that up and using the visuals is much more effective. Okay. Another thing to think about is just like the larger environments in terms of color, and reducing as much glare as you can. So don't use high gloss paint, for example, because the glare gets really strong for their eyes, and then it might also just look very frightening. And if you, let's say you wax the floor, so now your hardwood floor is nice and shiny, and then one day I wake up and I walk down the stairs and I start screaming and I refuse to walk on the floor because the glare is too much and I can't see that there's a floor. So these are things when we're experiencing those changes, and you are seeing that there's some fear and some behaviors related to that, like try to figure out if it's environmental. Is it something that they're seeing differently, and now they're scared of it? It's not that they've just stopped walking. They can still walk, but they're refusing to walk on the floor because it's shiny now, right? So being curious about those things is really important. The other thing is just outside. If you can have and walking path, really, really nice to get out. Using the door chimes, just so you know when the door opens up, so you can kind of be there, make sure no one guards, which is essentially a door. The front door will just click and lock if they get too close. It's just a little, sorry, where the door will lock. Now this has to be done in collaboration with CLSD, just because it can be quite restrictive to do that way with locking doors and stuff. And so I just want to make that note, but it is a tool that can be used, but in collaboration. So I've had comments throughout my career just related to cameras, where it's like, oh, but if I could only have a camera in the living room or in the hallway, I could see that they're safe. And then they wouldn't walk into traffic, and then they wouldn't be in danger, that kind of stuff. And so I really wanted to kind of dive into that with my research. And so there are a couple, not many, but a couple of European studies that have been concluded on this. One of them used cameras, and that included cameras in the personal bedrooms, okay? And bracelets, just to use to track their whereabouts. So essentially it was a GPS tracker, okay? So the one with the cameras, this was a special care unit. It was restraint free, but they did have the surveillance system on site. And the reasoning was to ensure the safety of the folks that would essentially wander at night and try to get out. So nocturnal wandering and inappropriate room intrusions, but also monitor for falls and aggression related injuries, that kind of stuff. Now, what they were seeing is that it was great that people had the ability and freedom to kind of move around the way they wanted to, but then again, having the cameras didn't stop any of the behaviors from happening, right? And so often individuals got lost in the building, and couldn't find their way back. And so even though they were monitored, I mean, there was still a risk of elopement. And so at the end of the day, having a camera in your home, in your bedroom, is an extreme violation of privacy, and not something that I would recommend in any shape or form. And keeping in mind too that even though you can see someone, and if they are on their way out, you're still going to have to go get them, So it doesn't take away any of your duties as a support worker. The other one that talked about the bracelets, this was again in the Netherlands. So they used the bracelets to track if they were wandering and stuff. And at the end of the day, it's the same deal. Like you still have to go after them. And it turned out, you know, oftentimes people just want a companion. They just want someone to walk with. They just want to go for a walk. So why are we not putting our shoes on and go walking, right? So it doesn't necessarily make it any easier for team members if there are cameras, because your job stays the same, okay? And also with the violation of privacy, I would say absolutely not recommended. So I have it on here because I've had questions. I did a little dig into it. This is what I found. So it was interesting, very interesting to read those. So moving into supportive interventions for change. So I actually, in my research paper, called this chapter Supportive Interventions for Behavior, and then decided to change it because at the end of the day, what we're seeing is changes, and behavior is related to the change. And so how can we support that, right? So as of being person-centered while meeting the individual where they're at, I will show a list of tools that I wanted to highlight that we can use when we're doing that work. Using the life story, career characteristics, hobbies, like know the individual that you're supporting and know who they used to be. Know what life they used to live. And don't try to alter that perception of what's happening. Because if you do that, it'll just cause more confusion and they most likely will get really angry with you. So if someone's waking up one morning and they say, okay, I'm going to go to work today, let's get dressed. And if you say, well, no, you retired 20 years ago, but their perception in that moment is that they're going to be going to work. They're going to get really upset with you if you say that. So, I mean, going with the flow a little bit and be like, okay, well, let's get dressed and have breakfast, see where we're at. Can you pop in and visit the work? Can you go run an errand and say, you know what? Today's a day off, but I could really use you in the grocery store today, right? And then try to go with the flow and don't alter that perception for them. And the last one is planning. So engaging in that proactive service planning related to palliative care. In the earlier stages, if the individual wants to and is able to partake in what end-of-life care will look like for them, by all means, please include them in that. Setting this up for ahead of time is very beneficial. So these are the tools I want to present today. Okay, so these are all developed by Helen Sanderson and Associates, person-centered thinking. I'm sure it's familiar for many of you guys. Now there's a whole spectrum of tools to use, but I've kind of pulled out the ones that I like for this particular population when they go through the stages of neurocognitive disorder. So what I want to go through is the one-page profile, important 2 and 4, communication chart, good day, bad day, and also the learning log. So our one-page profile, it looks a little bit different for everybody, but essentially what it is supposed to be is an at-a-glance information about a person. Okay, so let's say you're walking into a group home, let's say you're walking into a patient room in the hospital, and you haven't met them before, or you've only been with them a couple of times. This is like your need to know information. Like, what is it that people love and appreciate about me? What are my hopes and wishes? What are the things that I love to do? And what are the best ways to support me? And these are fairly easy and quick to kind of fill out if you're in a pinch. If you're not in a pinch, I would encourage you to take the time, do it with teams, caregivers, the individual themselves, that kind of stuff. But every situation is different. And sometimes we just need to have something down on paper, and that's okay. But essentially, this would help someone who maybe they're in the hospital because they had a fall and now they're being even more confused because of the neurocognitive disorder. And as a nurse, For example, you walk in, maybe they're being aggressive and saying, oh, I need to go get my medication because that's in the kitchen. And, you know, they're saying things that doesn't make sense to you, but it's real for them. Okay. And so then being aware of a routine where it's like, it's very important for me to get my medication at 8 a.m. every morning and I take it in the kitchen, right? It's such a simple little thing that could minimize a lot of confusion. The other one is important to and for. So what's important to a person is what makes them feel happy and fulfilled. It could be having the opportunity to go out for a walk, having the opportunity to go grab a coffee at Tim's, that kind of stuff. What's important for them is what helps them stay healthy and well. So for example, taking medications on time, that's important for them. If someone lives with the diagnosis of diabetes, it might be really important to them to go and have supper out at a restaurant once a week as a social component with somebody. But it's important for them that we try to plan what they order ahead of time because of their diabetes. For example, this is very simplified, but that's essentially what it is. And then we want to find the balance between the two, which is really important. And this is the same when we have a development of a neurocognitive disorder as well. What's important to and for someone might change a lot. And so that list might be really long. But at the end of the day, making sure that they stay healthy and also happy and fulfilled is important. This one is a communication chart. There are many different versions of this out online if you were to Google it, but essentially what it is when we're using behaviors as communication, what does the different behaviors mean? We always want to get curious about what's being displayed and then understand what they're trying to communicate. So when I talked about my example with the glares and the shiny floors, why is someone standing at the top of the stairs screaming? What does it mean? Well, they're scared because the floors are too shiny. Okay, so what do we do about it? Well, maybe we have a carpet or a rug that we put down for them so they can walk on it, right? That's a different color. That's just an example, but essentially what it is, it's at this time when we see this, what does it mean? What do we need to do? It's a really quick tool to use when someone also has nonverbal communication for someone to get to know them. The good day, bad day, I use a lot for talking about known triggers. So what does it take for someone to have a really good day? And what does it take for someone to have a really bad day? And what will it take for us to have more good days and less bad days? Again, when someone lives with a diagnosis and the progression of a neurocognitive disorder, this also might change. So making sure that we stay updated on these documents so that we can follow routine and make sure that we know what the known triggers are at all times. Which brings me to the learning log, okay? So this learning log talks about kind of what we're seeing, like changes in a person. So we want to plan to change our support strategies that we're using more often than what we would do for someone who does not have a neurocognitive disorder, and then learning from that day-to-day interaction and situations. And I know in agencies and within the government, I mean, there's incident reports, there's tracking, there's, you know, lots of paperwork, which is great, but often that also gets logged and then put away, it gets filed and put away, right? So making sure that we have this learning log so that we can keep kind of a tally on what's happening, and then bringing that up on a monthly basis is beneficial because change sometimes can happen that quickly. All right, Lily, you're doing great. Okay, so we're at the last slide here, and then we can, I'll open up for some feedback and questions, okay? So for a quick summary, there are gaps related to the collaboration to provide wholesome support for this dual diagnosis. Okay, and it is what it is. But like I said, I'm hoping to spark some motivation and a bit of a fire under some people today, so we can make change happen. There is also a lack of resources and training for staff members, but there are some resources out there, like I've showed you guys today, and I think we can learn from a lot of it. The use of person-centered tools can be very beneficial to support the future changes that might happen. And then creating plans with the individual, if possible, and also the service providers, family members, anyone who's close with them from the start of the diagnosis all the way down to potential palliative care and end of life. Aging in place is great to minimize confusion. We should be doing that if at all possible at all times. And then doing that regular screening for neurocognitive disorder after the age of 50 or 40 if someone is living with a diagnosis of Down syndrome. That's what I have. Thank you for listening to me, and I'm really sorry about Lily, but this is kind of what you get when you ask someone on maternity leave to do this.
There's no need to apologize, Lily. You did very well, and we're always happy to have you as a co-host on anything. We'll open it up. We have about 12 or 13 minutes for questions or comments or that kind of thing. If anyone has anything to add or questions, I've been monitoring the chat. We don't have anything yet. Oh, we have a affirmation of the cutest distraction ever, which I would concur with. Any specific presentation questions? We can also take those. I will also pop my email in the chat, so there might not be questions right now, but there might be some things that pop up for folks later. I will, yeah, I'm just gonna do that right now. I'll put my email in the chat so you can get in contact with me if you have any thoughts or questions, and I can make sure that Sissel gets that information. Not seeing very many questions, so then you were obviously very clear in all the information that you shared.
That's good.
Yeah,
I'll take it.
oh, there is a question. So Mackenzie is just saying they are curious about the use of cameras in homes for people with neurocognitive disorders in homes like assisted living or places with less supervision than a group home, long-term care, or personal care home, for families to be able to monitor their loved ones.
Mm-hmm. This is such a tough one because I understand from a safety perspective that we really want to. But in all honesty, and I know it's not like this, but I would want it to be this way, that we could instead put our energy into adding more people to support this individual so that you'd be able to go a bit more with the flow. Because think about being monitored 24/7. And at the end of the day, who's going to be watching? Like, are you sitting in the staff room watching the cameras? Because I mean, if you're doing that, then you might as well go and be out there with them, you know? So I understand from a safety perspective that sometimes we want that. But I would say it's better to be using, you know, maybe the bracelet so that you can track, or even the wander guards so that maybe the front door clicks on you and you can't actually go outside without somebody with you.
All right. Yeah, that is helpful, Sissel. Thank you. Trista is just sharing some feedback from her experience as well. So thanks, Trista.
Thank you for that. And I mean, like, the resources from when I talk about Helen Sanderson, you can Google them. Like, they have an amazing website where they will talk about how to use the tools and when to use them and all that kind of stuff. And you know, if your loved one is changing environments at any time, going to the hospital, that kind of stuff, it's nice to bring a couple of things for the staff there to use, so that everyone like your loved one feels safe, and also that whoever is on staff at the hospital also feel confident in that.
Thank you, Amanda. I've just posted the link for some Helen Sanderson tools.
Amazing.
Those tools are also useful in a variety of social work settings or environments, or anywhere you're supporting someone in general. I've used them as well in lots of different environments. So thanks for bringing that to our attention, Sissel.
Of course.
We'll give it a minute or two for the last minute questions. But again, want to be respectful of the lunch hour and might even get you off a few minutes early so you can quickly have, you know, a snack break or a washroom break or something before you head into your day. So I think we'll maybe just stop the recording for now. And